Welcome. In this video, we're going to discuss principles of coronary occlusion identification based on a single ECG lead. There are three markers of occlusion that we're going to discuss. First, there is relative J-point elevation. That is J-point elevation relative to the QRS. We'll call this relative elevation. Second is proportional T-wave area. This is increasing area under the T-wave in proportion to the QRS magnitude. We'll call this proportional area. Third is T-wave contour, change in the shape of the T-wave. We will call this T-wave contour. First, let's get clear about what J-point or ST elevation means. We measure at the J-point, highlighted right here, which is the junction between the QRS and the ST segment. We measure this relative to the PQ junction, highlighted here. Per the American College of Cardiology and the American Heart Association, the PQ junction is what is used, not the TP segment. The first marker of ischemia is relative elevation, increasing J-point elevation to QRS magnitude ratio. Here you can see the QRS complexes are about the same in magnitude, but the J-point is much higher on the right, and therefore there's a higher J-point to QRS magnitude ratio. Of the three markers, relative J-point elevation is the established metric, while absolute J-point elevation is the metric of the STEMI criteria. Relative to the QRS J-point elevation is the metric of the Smith modified Sgarbossa criteria for occlusion in left bundle branch block. First of all, don't worry, we'll cover this again, but by the accepted metric I mean that the acceptance of the Smith modified Sgarbossa criteria by the ACC marked the acceptance of relative rather than absolute J-point elevation as a measure for identifying occlusion in appropriately discordant left bundle branch block tracings. If you need a refresher on appropriate discordance in left bundle branch block, you can watch my video on left bundle branch tracings. The tracing on the bottom right is not a left bundle tracing, but it has an QRS to J-point ratio of 0.7. Our second marker of occlusion is T-wave contour. The normal QRS on the left sort of has a round T-wave, but that complex wouldn't necessarily get your attention in general. It's normal and the T-wave is small. However, on the right, you can see a large, convex, symmetrical T-wave. To understand the difference between a concerning and a less concerning contour, let's look at two waveforms with some J-point elevation. Here's a spot from your sheet demonstrating a less concerning, more concave contour on the left and a more concerning, more convex contour on the right. I like to think of contour as the tiebreaker, something to push you one way or another when you're concerned about relative elevation or proportional area. Finally, we get to proportional area, increasing area under the T-wave to QRS ratio. This is difficult to quantify, requiring calculus, but it's easy to spot once you've learned to see with proportion eyes. And let's be clear here, these ECG waveforms with the calculations done through a Python program are done to help teach. I'm not expecting y'all to be doing math while you're looking at ECGs. So here's why I say the proportion principle is the fundamental principle for identifying coronary occlusion. As the ECG changes in the setting of coronary occlusion, you may or may not see ballooning of the T wave, nor will you necessarily see J-point elevation, but you will see the area under the T wave increase in proportion to the QRS magnitude until infarction is complete or reperfusion occurs. We're going to keep coming back to this concept, and the sooner you can learn to see with proportion eyes, the sooner you will learn to spot ischemia. So, what do you call a tracing that has concerning markers of occlusion but does not meet STEMI criteria? We call that a hyperacute T wave. The proportion principle is the Smith-Myers hyperacute T wave definition. Question: are we mandated to identify hyperacute T waves like we're mandated to identify STEMIs? Since 2022, the answer is yes. The ACC and AHA guidelines regard hyperacute T waves as a STEMI equivalent. It's therefore incumbent upon emergency physicians to recognize hyperacute T waves and activate the cath lab if they are concerned for occlusion, and it's incumbent on interventional cardiologists to take a patient with these findings and a concerning clinical story to the cath lab based on the same guidelines. Question: what's the simplest way to identify a hyperacute T wave? The answer is being able to fit the QRS complex within the T wave area. This is illustrated on the left. This can work and often does work for de Winter T waves as well, which we can think about as hyperacute T waves with a depressed J point. The problem with this definition, as illustrated on the right, is that it is insensitive. Only the most obvious hyperacute T waves satisfy this principle. Since we noted that, let's revisit contours since it's the most intuitive and least quantifiable of the three markers. Consider tracing A and tracing B. Both lead V3 from their respective 12-lead ECGs. Think about which one is more concerning to you. Assessing contour is a pretty intuitive task, but there are at least three specific features of the T wave that we can point to. First, and again, convexity versus concavity. While I wouldn't call A convex necessarily, B has a certain concavity on its upslope that is reassuring. Second is symmetry of the upslope and downslope. A has a more symmetrical upslope and downslope. You could more or less describe these lines with the same equation, just put a minus in front of the upslope equation for the downslope. The same is not true of B, which has a steeper and more linear downslope compared to the upslope. A is also just fatter than B. Anyone with ECG expertise would immediately recognize that A is more concerning than B, and this is largely based on the T-wave contour. The relative J-point elevation in B is higher than in A, which may or may not be more concerning. The proportional T-wave area for both of these happens to be equal. We're going a bit off topic here and discussing some subtleties, hence the nice light gray slide background. Junior learners, don't panic. An advanced learner might recognize that A has a barely perceptibly depressed J point, which is consistent with a de Winter hyperacute T wave. and that B has a somewhat reassuring J wave, which is less visible on the Python output that we just looked at. This would help with the decision about which of these tracings is more concerning. So let's take the time to discuss what a J wave is. A J wave looks like a little hook or notch at the J point. J slur looks like a shortcut was taken from the QRS to the ST segment that bypassed the J point. Both are structural rather than ischemic features of the ECG. But be careful dismissing chest pain in an older or high-risk patient with these ECG features. Since I already opened this can of worms with that equivocally depressed J point, the winter T waves are, again, hyperacute T waves with a depressed J point. They are seen in 2% of LAD occlusions and are usually located right here where I have them circled on the right. Okay, back on topic. Looking at the associated ECGs for A and B is like looking at an answer key. Looking at the rest of the ECG for A, we see all sorts of concerning proportions in AVL in V2 through V4, and we also see reciprocal depressions in the inferior leads and in V6. This ECG is diagnostic of LAD occlusion. What are reciprocal depressions and what does it matter which leads are concerning where? We'll cover this in the next video. ECG for B, on the other hand, is consistent with benign early repolarization, a topic we will revisit. Yes, there is ST elevation in V2 through V5. In fact, this ECG meets STEMI criteria. There's 3 millimeters of ST elevation in V2 through V3. But in addition to the reassuring J waves or J slurs in V3 through V5, V2 through V5 are not concerning from a proportion standpoint. The QRS complexes are much greater in magnitude than the area under the T wave. That is, except for lead V3, which poses the transition lead problem. Transition leads are single precordial leads that can have concerning relative J point elevation and proportional T wave area. It's the lead where the dominant S waves transition to dominant R waves. It often has less QRS magnitude but equal T wave area in comparison to its contiguous, that is, adjacent leads. In shifting your radar from millimeter counter to proportion spotting, I emphasize tracing B for this reason. Looking at the contiguous, that is, adjacent leads is reassuring. We can appreciate at least 3 millimeters of ST elevation in V2, but in proportion to the QRS, this amount of elevation is unconcerning, and so is the area under the T wave. V4 has a J wave, which is itself reassuring, and even if we use the J wave peak as the J point height, this is unconcerning in proportion to the QRS. So we do not have 2 contiguous concerning leads here. Problems posed by the transition lead can be resolved by looking for occlusion on the entire ECG rather than just one lead. To recap, contour helped us discriminate which tracing was more concerning, but the presence or absence of contiguous concerning leads and reciprocal changes let us be sure. Let me emphasize that we did not need to go on to the De Winter or early repolarization side quest to get this right. Also, never forget that acute coronary occlusion is a clinical diagnosis and that your impression of the patient at bedside should play an important part in what you do next. As a preview of our next topic, contiguous leads are leads that correspond to a territory of the heart. A territory is served by a coronary artery. There are 3 coronary arteries, and there are basically 3 territories.